All right, friends, moving on to the next segment of questions. We have question number 22. 21 was the last question that we did. Okay. Now question number 22, what is meant by superfecundation? Fertilization of two or more ova in one intercourse, fertilization of two or more ova in different intercourses in the same menstrual cycle, or does it mean fertilization of ova and then its division, or fertilization of second ovum first being implanted? So the correct answer for this is B, fertilization of two or more ova in different intercourses. Alright, so I always used to remember superfecundation as twins who are the same age, okay, but one is white and one is black. Classic example of fertilization of two or more ova in different intercourses in the same menstrual cycle, and you will not forget, and you should not forget, it is superfecundation. That is superfecundation. Okay. Fertilization of two or more ova in one intercourse is going to result in something which is called as dizygotic twins, right? Right? Superfecundation is a type of twin when there are different intercourses but in the same menstrual cycle, but different intercourses, alright. So this is also a type of twin, but it is different than the regular dizygotic twins. Wherever in these are also, they are dizygotic twins, but the only difference is that in superfecundation that they are from different intercourses. There is another term which is called as superfecundation. There is superfetation. There is another term which is called as superfetation. Right, superfetation means that there is fertilization of two ova are fertilized but in different menstrual cycles. Okay, that is the difference. Different menstrual cycle, not in the same cycle. That is superfetation. It has not been documented in humans, but it is theoretically possible. It is not documented in humans. Now, why is it theoretically possible? It is theoretically possible because if you remember a little bit about your implantation, you will realize that if this is the uterine cavity, alright, this is the uterine cavity, and this is the embryo which is trying to implant here. This is the embryo which is trying to implant here, right? Now this embryo, certain important points about the embryo I want to tell you is that this conceptus, let us just talk about implantation. Let us talk about implantation and the important points about implantation. Before implantation can happen, we have to remember that at the point in time when the fetus is, when the zygote is preparing from implantation, at the same time what is happening is that the decidua, the lining of the endometrium, is also getting ready for implantation to receive this zygote. So both are taking place simultaneously, alright, but in different locations of course. So when we talk about the conceptus which is formed after fertilization, alright, so let us begin with, let us talk about the important topics. Let us talk about the important points about fertilization, let us talk about the important points about implantation, and then let us talk about the important points about the decidua. These are the three things that I want to discuss here with you today on this topic. Okay, so let us talk about fertilization. Okay, let us talk about fertilization. Now, what are the important points to know about fertilization? Now, fertilization, you see, it takes place in the tube. Which part of the tube? Ampulla of the tube. right? Now the egg is fertilizable for a period of 24 hours and a sperm is fertilizable for a period of 72 hours. These are all important question points, okay? All important one-liners. Sperm is fertilizable for 72 hours. The egg, on the other hand, is fertilizable for 24 hours. The fertilization takes place in the tube. It takes place in which part of the tube? It takes place in the ampulla of the tube. That is why ampulla is also the most common site of tubal ectopic. Okay, that answers another of our question. Okay, another of our one-liners. So anyway, so fertilization has to take place in the tube and the sperms have to be reached the tube. So the sperms, they got deposited in the vagina, but the sperms, they have to reach the tube. So sperms, they reach the tube in 30 minutes after ejaculation. Okay, so after ejaculation, the sperms reach the tube in 30 minutes. After intrauterine insemination, when they are deposited inside the uterine cavity, they reach in 5 minutes. Alright, that is the difference. Now before the sperms, they should reach the tube, the sperms undergo a process which is called as capacitation. Capacitation takes place in the female genital tract. Okay, which part of the tract? Mainly the tubes. The major part of capacitation takes place in the tubes, but it starts in the cervix. And what happens in capacitation? During the process of capacitation, the sperms, they gain hypermotility. That is the capacity to fertilize. Okay, so capacitation, the sperms gain hypermotility, the capacity to fertilize, that is called as capacitation. It takes place in the female genital tract. Its major part takes place in the tube. It starts in the cervix and it takes a total of 7 hours. The whole process of capacitation takes place about 7 hours, right? Now this capacitation is so important. Okay, this capacitation is so important. That is why what we do is the cervix, the role of the cervix, the role of the rest of the cervical secretions, everything has a role in promoting fertility as well. Now, next important point about fertilization is the sperm, it binds to the zona pellucida 3. So the oocyte at the time of fertilization is still surrounded by the zona pellucida. So sperm binds to zona pellucida 3. So zona pellucida 3 is the sperm receptor. Alright, and that triggers the acrosomal reaction. In the acrosomal reaction, the main enzyme, a lot of enzymes are released, but the main enzyme that is released is hyaluronidase. Right, and then further the sperm binds to zona pellucida 2 and then leads to a cortical reaction that leads to release of calcium ions, and further it leads to a zona reaction, and this leads to completion of meiosis 2. Anyways, this zona reaction or zona hardening, what it mainly does, it prevents polyspermy. So important thing to remember, first happens acrosomal reaction, hyaluronidase is released, the sperm is able to penetrate deeper into the zona pellucida, then sperm is able to bind with zona pellucida 2, then cortical reaction is triggered, there is release of calcium ions from these cortical granules, and that trigger ultimately the zona reaction and the completion of meiosis 2. So your question that was arised, which I also told you before during the menstrual cycle discussion, was that the second polar body, that is released at the time of fertilization? This is another important question that is asked, that when is the second polar body released? Alright. Now, after this what happens? Ultimately, completion of meiosis II, there will be male and female pronucleus. And you will get a zygote. This zygote has to undergo cleavage, and the first cleavage of this zygote happens 30 hours after fertilization. Okay, the first cleavage happens 30 hours after fertilization. Then this cleavage state embryo, it stays in the tube for 3 days. And another important question, the zygote, when does the zygote enter the uterine cavity? The zygote enters the uterine cavity on day 4 of fertilization. Okay, so zygote enters the uterine cavity on the 4th day of fertilization, and this happens at the 8-celled morula stage. 16-celled stage is also morula, but it is in the 8-celled morula stage that it enters the uterine cavity. That happens on day 4. Okay, so the first cleavage of the zygote happens 30 hours after fertilization. It stays in the tube for 3 days, and then it enters the uterine cavity on day 4 of fertilization in the 8-celled morula stage. After this, what happens? After this, on day 5, it is a blastocyst. The embryo has now become a blastocyst, and it undergoes zona hatching. So you understand that the developing zygote, the cleavage stage embryo, the morula, is surrounded by the zona pellucida up till day 5. Once the zona hatching happens, the blastocyst, it hatches out of the zona pellucida, and then it implants. So implantation begins day 6 of fertilization, right? Fertilization, and it is completed by day 10 of fertilization. So implantation is happening between day 6 to day 10. This something corresponds to day 22. Day 20 to day 24. Right? Day 20 to day 24 of the menstrual cycle, that is when implantation happens. What is the site of this implantation? The site of this implantation is the upper posterior wall. Right? Another important point about implantation is that it is interstitial implantation. Right? So interstitial implantation means that it is, what does interstitial implantation means? Interstitial implantation means that the uterine lining or endometrium is restored over the implanting embryo. Alright, and this interstitial lining implantation is completed by day 10. Very, very important point, completed by day 10. So what is this interstitial implantation that we are referring to? It is something like this. This is what I was telling you, that this is the uterus, this is the this is the uterus, this is the embryo which is trying to implant, this is the decidua basalis, this is the decidua basalis, this is the decidua capsularis, and this, the rest of the decidua, is the decidua parietalis. Right, and this is the potential space, that is decidual space. So this is the decidua basalis. The decidua is that part of the endometrium when the endometrium gets ready under progestational effect, it changes its character, it becomes ready to implant, that is called as decidua. So in other words, they ask you also this question sometimes, that the decidua formation is completed by day 10. Right, because it is the endometrium after implantation. That is decidua, and that is why the decidua formation is completed by day 10. Now this is the decidua basalis, this is the decidua capsularis, this is the decidua parietalis. There is a potential space, this is the decidual space, right. This states, question is asked, the space gets obliterated by 14 to 16 weeks. That is why, because of this potential space, there is a theoretical possibility of having a superfetation, which has not been documented in humans so far. It is documented in animal species. Anyways, what happens with progressive increasing in uterine size, in the progressive increasing in the size of the gestation, these decidua capsularis and parietalis, they fuse later on to form the decidua vera ultimately, and this fusion is going to happen when the decidual space gets obliterated by 14 to 16 weeks. Alright, now moving on to the next question, question number 23 we have already done. Let us move on to question number 24. What is question number 24 here? Question number 24 here is, all of the following are used for induction of labor except PGEF2, E1, E2, misoprostol. Now E1 and misoprostol are the same thing. Anyways, your answer is PGF2 tablet. PGF2 tablet is not used for induction of labor. So let us just talk about the various prostaglandins that are used in obstetrics. Just a very brief about the various prostaglandins, right? The various prostaglandins that are used in labor is, one is your misoprostol, which is PGE1. There is a dinoproston, which is PGE2, right? Now this dinoproston is this misoprostol or PGE1 for induction of labor. It is used off label, okay? It is not recommended, but it is used off label, and it is used in doses like 25 to 50 micrograms. It is used in these small dosages. Dinoproston, on the other hand, it is very commonly used for induction of labor, and this comes in the form of gel, it comes in the form of inserts, right? It comes in the form of intracervical gel or vaginal gel, different formulations. So this dinoproston is also there. So important point about misoprostol is that PGE1 is absolutely contraindicated for induction of labor in previous cesarean section. So this is definitely not given, absolutely contraindicated in previous cesarean section. Dinoproston, on the other hand, a single dose can be given for induction of labor in previous cesarean section. Otherwise, usually what is done is your every 6 hourly this gel can be repeated, every 6 hourly for 3 doses. 3 or 4 doses depending upon the findings. Now the other prostaglandin that is available is the PGF2 alpha, which is called as carboprost. Now this carboprost is used in postpartum hemorrhage treatment. It is used there. It is not even used in active management of third stage of labor. It is used for postpartum hemorrhage prevention. So this is there for your as far as your prostaglandins are concerned. But the problem with carboprost is that carboprost is contraindicated in asthmatics, okay? So this is an important point that to remember, that Carboprost is contraindicated in asthmatics. If you talk about dinoprostone, it has no as such specific contraindications, just certain caution in liver and kidney diseases. And even misoprostol does not have many important contraindications, medical contraindications per se, but definitely it is contraindicated in previous cesarean section. Now talking about induction of labor, these agents, these prostaglandins, okay, these agents, these prostaglandins which were, they were used for cervical ripening. Now induction of labor is two parts, cervical ripening and then a stimulation of contractions. Whatever agents are used for ripening will ultimately induce contractions as well, but cervical ripening is to be done, and these ripening agents are used. We have your stripping of membranes is one non-pharmacological method. We have Foley's catheter, which is intraamniotic, intracervical Foley's catheter, balloon placement, right, that is there as a method of cervical ripening, right. We have osmotic dilators, and we have drugs like, so for cervical ripening, these are the non-pharmacological method. We have drugs like PGE2, PGE1, and oxytocin can be used, and then we have the hyaluronic acid, commercially not that commonly available, mifepristone, that also helps, but usually not commonly used. Main induction agents are these. Of these also PGE2 is the most commonly used, which is dinoprostone. PGE1 is used off label. Misoprostol is used off label. This is about cervical ripening. But the important point here is something called as Bishop score. When do we use the cervical ripening? We use the Bishop score to calculate whether we need to give cervical ripening agents or not. So a Bishop score involves, we see what characters, we see cervical dilatation. Cervical dilatation is the most important of all the criteria, is cervical dilatation. We see cervical effacement. When we see it in percentage, it is the Bishop score. When we see in centimeters, it is modified Bishop score. So cervical effacement, station of the presenting part. Then we see the cervical position, mid position, anterior position, and we also see the station. And the cervical consistency, right, soft or firm. So of these, the above three are most important, and among these three also the cervical dilatation is the most important factor. All right. So the total score of a Bishop, the total score can be 13. All right. Out of this 13, if the score is 4 or less, if the score is 4 or less, it means that it is an unfavorable cervix and cervical ripening is needed. And if it is a score of 9 or more, it means that there is high likelihood of successful induction. Right. There is no need to remember the entire Bishop score, but just a parameter you can say that 2 centimeter dilated cervix, 80% effaced, soft, mid position, -1 station. This corresponds to more or less to a score of 9. So if you remember this much, you will know that this is a success, this is a good score. 2 centimeter dilated, 80% effaced, soft cervix, mid position, and -1 station. This is a good score, successful induction. All right. Now let us move on to the next question. Question number 25. Acute fatty liver is commonly seen in pregnancy at the third trimester. This is acute fatty liver of pregnancy which is seen commonly in the third trimester. All of these complications, you see the obstetric cholestasis and your preeclampsias and HELP syndromes and acute fatty liver of pregnancy. These complications, they are mostly seen in the third trimester. So let us just talk about what kind of questions are usually asked in acute fatty liver of pregnancy. Say acute fatty liver of pregnancy is like an encephalopathy. The liver is giving up. Alright, so there is a hepatic encephalopathy which usually happens in acute fatty liver, and acute fatty liver of pregnancy, like HELP, like severe preeclampsia, there are a lot of overlapping features between HELP, severe preeclampsia and acute fatty liver of pregnancy, right? So acute fatty liver of pregnancy more or less becomes a diagnosis of exclusion, and it doesn't really matter much. Why? Because the management does not necessarily change. Even if it is HELP, even if it is acute fatty liver of pregnancy or preeclampsia, the treatment is supportive and also termination of pregnancy at the same time to begin with. So necessarily the distinction, to make a distinction between these three things immediately does not matter much, right? But since the question is asked, right, we have to understand what is important and which are the conditions which are our differential diagnosis in such a situation. So our differential diagnosis in such a situation is that between hepatitis, which will be, let's say, viral hepatitis, HELP syndrome, acute fatty liver of pregnancy, and okay, obstetric cholestasis I will include, but not necessarily. But anyways, for the comparison purposes, let us just complete this differential diagnosis. This is, okay, so viral hepatitis, we will have your HELP, or we will have our acute fatty liver of pregnancy and obstetric cholestasis. So viral hepatitis is going to present in any way like any viral hepatitis presents. Alright, so or viral hepatitis presents in a non-pregnant patient. It is going to present in the similar way. So nausea, vomiting, malaise, so any of those symptoms will be there. What importantly, what will happen in viral hepatitis is that going to be the liver enzymes, that is the AST and the alkaline, AST and ALT, they are going to be elevated in thousands. They are going to be elevated in thousands. The serum bill is going to be very, very high. All right, 8-10 milligram per deciliter, right? 8-10 milligram per deciliter, such are going to be the values. All right, and there is going to be hepatomegaly. So if in the question the liver enzymes are elevated, AST elevated, much elevated in the thousands, there is hepatomegaly, there is severe jaundice, the diagnosis more so goes in the favor of viral hepatitis. All right, so, and very importantly, the Hep E hepatitis, the Hep E hepatitis can be that has very high mortality in pregnancy. Okay, so whenever there is viral hepatitis, you know, we go for conservative management. We go for conservative management in the acute stage of hepatitis. We don't want the woman to deliver, otherwise she is going to have a lot of bleeding complications. Okay, so in the acute stages we want to do conservative management, but in HELP and acute fatty liver of pregnancy, that is not the case. We want to deliver the patient as soon as possible. So HELP syndrome is also seen in the third trimester, most commonly in the third trimester. Similarly, your acute fatty liver is also most commonly seen in the third trimester. Obstetric cholestasis can also be seen in the late trimester, late second trimester. Now, what an important point about HELP syndrome and acute fatty liver of pregnancy is that the liver enzymes are going to be raised in both the situations, right? So, liver enzymes are going to be raised, but in acute fatty liver of pregnancy, what will happen is that they are not going to be raised too much. So, they are going to be raised, but not too much. That is the difference. Then HELP and acute fatty liver will have almost similar kind of a clinical picture. Hemolysis is going to be present in both. Hemolysis can be present in both. Okay, low platelets can be present in both. Low platelets can be present in both. BP can be high in both, or BP can be normal in HELP. Okay, in fact, you know, 15% of HELP will have normal BP. Okay, HELP is hemolysis, elevated liver enzymes and low platelets. This is what HELP is. It is the complication of severe preeclampsia, but 15% can have normal BP. In acute fatty liver of pregnancy, the BP can be normal, or it can be more, it can be less, it can be anything. So they usually do not, commonly present any symptoms, commonly present any differentiating symptoms. Then the most common presentation of with HELP syndrome is usually epigastric pain. Epigastric pain or right upper quadrant pain. This is because of hepatic capsule dilatation. Capsule dilatation or stretching. Okay, so this is usually because of that. On the other hand, very importantly, acute fatty liver of pregnancy, how will you differentiate? If all these symptoms are there and there is hypoglycemia, there is hyperammonemia, or if the question says shrunken liver, here the hepatic capsule is stretching, here shrunken liver, then the diagnosis goes in favor of acute fatty liver of pregnancy. Alright. On the other hand, obstetric cholestasis, the enzymes are elevated, but they are usually in their hundreds. They are not too much elevated, they are in hundreds. Pruritus is the main problem, not jaundice. Pruritus is the main problem, and your bilirubin levels are rarely more than 5 milligram per deciliter. So you have to understand that jaundice with obstetric cholestasis is rare. Alright, and the best test, question is asked, the best for obstetric diagnosis of obstetric cholestasis is serum bile acids. Serum bile acids, which when raised make the diagnosis of obstetric cholestasis. The recurrence rate of obstetric cholestasis is as high as 70%, as high as 17%. And very important point about obstetric cholestasis is that the risk with obstetric cholestasis, okay, so in HELP and acute fatty liver pregnancy, viral hepatitis, in all these three conditions, the risk is to the mother. The risk is mainly to the mother. So in acute fatty liver of pregnancy or in HELP, the management is supportive and termination of pregnancy. Right. Whereas in obstetric cholestasis, the risk is to the fetus. Fetal risk is the main. There is risk of sudden IUD that can happen. There can be sudden IUD at term. There is risk of meconium passage, fetal distress. All this is because of the toxic effects of the bile acids on the chorionic villi. Alright, toxic effects of, these are the toxic effects of bile acids on chorionic villi. Right. So what is the treatment? The management of obstetric cholestasis is, we want to keep the bile acids under control, keep the levels down. So the treatment is ursodeoxycholic acid. The treatment is with ursodeoxycholic acid and regular monitoring. For itching, we can give symptomatic relief like chlorpheniramine. And answer it importantly, there is termination of pregnancy at 37 to 38 weeks. 37 to 38 weeks, the pregnancy needs to be terminated because sudden IUD at term can happen. So once with obstetric cholestasis, pregnancy is beyond 37 to 38 completed weeks, one should terminate the pregnancy. Alright, so this is in brief about the obstetric cholestasis and the differential diagnosis. Another important one, potential question, is that sometimes this obstetric cholestasis, a gene is being studied. The gene is being studied for obstetric cholestasis, and that gene is ABCB4 gene. okay, ABCB4 gene, which encodes for MDR3. Okay, so this is another important point that you should remember. It's a potential question about, this is given in the latest edition of Williams, about this gene encoding for gene which is being studied for the obstetric cholestasis. Now moving on to the next question. Question number 26. Commonest cause for puerperal sepsis is, the correct answer here is anaerobes. If you ask me if in the options for puerperal sepsis, if in the option it was given the most common is mainly for puerperal sepsis, the most common is polymicrobial, okay. The most common is polymicrobial, followed by anaerobes as a group, and then followed by aerobes as a group, okay. So that is why, because polymicrobial is not an option here, and the rest all you have are aerobic organisms here, anaerobes is your answer here out of exclusion, because as a group anaerobes are a commoner cause than aerobic organisms. So this is about puerperal sepsis here. Just a few another bit of information given here. Now let us move on to the next question. Question number 27. All are correct regarding the device shown here except. Now this is placed, this device is, first of all, this is a vacuum cup, this is a plastic vacuum cup. It's placed 6 centimeter anterior to the posterior fontanelle, should generate excessive traction of effective vacuum of 0.8 kg per centimeter square. Traction is up, so this is the true statement. Traction at right angles to cup, that is also a true statement, and traction is released in between uterine contraction, that is also a true statement. The false statement is the first statement. So A is your correct answer. So this is the false statement here, because the placement of this vacuum is such, like this is the fetal skull, okay, and this is the posterior fontanelle which is triangular, and this is the anterior fontanelle which is quadrangular. This vacuum cup is placed in a manner that it is 3 centimeters here. So it is, the edges of the vacuum cup are something like this. Okay, this whole vacuum cup has a radius of 3 centimeters. So this is 3 centimeters here. Alright, so this vacuum cup is placed at a distance of 3 centimeters anterior to posterior fontanelle. Okay, or 6 centimeters posterior to anterior fontanelle. So let me just show it to you here. Let me just write it down here for you another separately, that what is the vacuum application. So for correct application of vacuum, alright, so what is done in correct application of vacuum? Important point to know is that the central point of cup, or the center of the cup should overlie the flexion point, okay, and this flexion point is located 3 centimeters anterior to posterior fontanelle, or 6 centimeters posterior to anterior fontanelle. Okay, ultimately the pressure that is generated, it is around 0.8 kg per centimeter square, which is somewhere equal to 600 mm of Hg. Okay, so these are the important points about the correct application of vacuums, right? Similarly, now let us just study about what is the criteria of instrumentation. Okay, criteria of instrumentation. What kind of questions are asked? What kind of questions are asked when we talk about instrumental deliveries? The questions that are usually asked and that have been asked in the past is what are the prerequisites, right? The prerequisites of where you can apply this thing. Where can you apply forces? What are the special conditions of forceps application? What are the special conditions of vacuum application? And how is vacuum different from forceps application? These are the main set of questions which I'm going to take into consideration right now for discussion. If you talk about the prerequisites of forceps application or instrumentation, the prerequisite is that it should be fully dilated. All right. Ideally, there should be occipito-anterior or occipito-posterior position. So the sagittal suture should be straight line. Head should be fully rotated. All right. So this is the ideal position. All right. However, your vacuums can be applied on incompletely dilated os also, and it can be applied in mal-rotated head also. But ideally, your head should be rotated and it should be fully dilated. All right. Ruptured membranes should be ruptured. Consent should be there. There should be no CPD. Engaged head. Empty bladder. And very importantly, +2 station. Okay, very importantly, +2 station. Now all instrumentations are done at +2 station and more than that. So any forces which are applied at +2 station, which are called as low forceps. We have outlet forceps also. Outlet forceps are applied at station which is +3 or more than or equal to +3 station, or when the head is at the perineum. That is what is called as outlet forceps. Question is asked on this also. +2 and beyond, it is low forceps. Mid cavity forceps and high forceps are no longer applied in obstetrics. All right. Now, what are the special situations where vacuum can be applied? Vacuum can be applied in incompletely dilated cervix and mal-rotated head also. However, usually whenever there is incompletely dilated cervix, instrumentation should not be done. So ideally, fully dilated and occipito-anterior posterior positions. What are the special situations where forceps can be applied? Obviously, forceps can be applied in after coming head of breech. Very, very important question is asked on this. Forceps can be applied in after coming head of breech. Logically, vacuum cannot be applied there. It is face, obviously face, and your premature fetus, vacuum is not applied. So these are the special conditions where forceps is preferred. And dead fetus, forceps can be applied on a dead fetus. And even if I have to apply on something that is fetal coagulopathy, if at all you have to do something, you can apply forceps there. So these are the important points. What are the contraindications? Okay, so these are the important points about instrumentation. All right. Now, next important point about instrumentation you have to remember is how are forceps different than vacuum. So, if we talk about forceps versus vacuum, okay, in a nutshell, if we talk about forceps versus vacuum, we have to see that in forceps, the secondary, the 3rd degree and the 4th degree perineal tears, they are more common in forceps as compared to vacuum. In vacuum, overall, you see the fetal complications or fetal injuries, they are more in vacuum as compared to forceps. However, if fetal complications do happen in forceps, they are mainly because of incorrect placement of forceps, that they are either applied to anterior to posterior or to sideways, impinging on the structures, and they are incorrectly placed or excessive traction is applied, and then the forceps can lead to special kind of injuries like depressed skull fractures. It can lead to brachial plexus injury. It can lead to facial nerve injury and anterior eye injuries or corneal injuries. They will be more so if fetal complications. So if such kind of fetal complications will happen more so in forceps as compared to vacuum, and that also happens with incorrectly applied instruments. With vacuum, the kind of complications are a little different. They will cause cephal hematoma because of the because of the negative pressure that is created, subgaleal hemorrhage, retinal hemorrhage, lateral rectus palsy. Now such kind of injuries are more common seen in vacuums. In fact, vacuums have higher incidences of shoulder dystocia as compared to your forceps. Another important point that is sometimes debatable, what about intracranial hemorrhage? Intracranial hemorrhage rates are more or less similar. Intracranial hemorrhage rates are similar. This is according to the latest editions of Williams. Certain studies say that it is more in forceps, certain studies say it is more in vacuum, but more or less the intracranial hemorrhage rates are more or less similar. Okay. Now let us come on to the next question, which is question number 29. Patients of eclampsia or magnesium sulfate regimen are monitored for all of the following except respiratory rate. Is it respiratory rate? What is not done in monitoring such women? Urine output, knee jerk or sodium potassium levels. The answer is sodium, potassium and potassium levels. These are not done. So we have to understand that when we're talking about magnesium sulfur preeclampsia or magnesium sulfate in obstetrics, okay, magnesium sulfate for preeclampsia, in which situations do we give magnesium sulfate? We give magnesium sulfate whenever there is severe preeclampsia, or there is HELP syndrome, or there is impending eclampsia, right? Impending eclampsia or eclampsia, then we give magnesium sulfate, okay? Even when we give magnesium sulfate, you know, for this thing, so this is for when we give for eclampsia, that means the fit has already been, the seizure has already there, right? When we give for severe preeclampsia, HELP or impending preeclampsia, that we are giving for prevention of future seizures, right? So what are the important points that you have to remember? That what is the mechanism of action? The mechanism of action is basically it acts both centrally and peripherally. Okay, so it acts both centrally and peripherally. Important point. And it acts basically, it blocks the NMDA receptors in the brain, and it will potentiate the adenosine action, and it decreases the release of glutamate. So all of these it does to prevent seizure activity. Now how is it given? The protocol can be divided into so many different types. We have the IM plus IV protocol, which was given by the Pritchard regime. Then we have the Zuspan regime, which is the IV regime, right? And we have IV regime is given by Sebai also, with different dosages, but mainly IM plus IV is the Pritchard regime, and we have the IV regime, the Joustan regime, and the Sibai regimes are also their protocols. So these are the various sort of protocols named by these people, named after these people who have given these protocols. And what is important is that we are measuring before, whenever we are giving this magnesium sulfate, so we are measuring urinary respiratory rate, we are measuring the urine output, and we are measuring the deep tendon reflexes, right, the knee jerk. Right, because we are doing these things because we are not measuring the serum levels. Okay, so respiratory rate, magnesium sulfate leads to respiratory depression, that is a side effect. Urine output, you have to remember, magnesium does not cause decreased urine output, but magnesium is excreted renally. Okay, but it does not cause oliguria as side effect. So if there is oliguria because of renal involvement in the severe preeclampsia or eclampsia, what will happen? Magnesium toxicity is going to be precipitated. So magnesium is excreted renally. That is why urine output is maintained, is to be there, and urine output should be maintained at least at 30 ml per hour minimum. This much should be there. And you see the knee jerk. We see for the knee jerk. So what are the therapeutic levels? What are the levels of magnesium sulfate? Important levels of magnesium sulfate to remember. The therapeutic levels of magnesium sulfate are basically 4 to 7 milli equivalent per liter. This is equal to 4.8 to 8.4 milligrams per deciliter. This is important point. Question has been asked on this. The therapeutic level of magnesium sulfate, right, is 4 to 7. However, these are not measured clinically most of the times. Only in the face of, oliguria, only if there is renal involvement, if there is oliguria, only if, serum creatinine levels are raised, then we measure these levels. Otherwise, we do not measure these levels of magnesium. Then loss of patellar reflex. Loss of patellar reflex happens at values 10 milli equivalent per liter, which is equivalent to 12 milligrams per deciliter. Beyond 15 milli equivalent per liter, there is respiratory depression and arrest. Okay, this will happen beyond, and beyond 30 milli equivalent per liter, what happens is cardiac arrest. So whenever there is, respiratory depression and severe toxicity, right, then if there is loss of patellar reflex, we can simply stop the magnesium sulfate. Okay, so if there is loss of patellar reflex, we can simply stop the magnesium sulfate infusion. But if severe degrees of toxicity are there, then what is the antidote? The antidote for magnesium sulfate is calcium gluconate. Okay, 10% of calcium gluconate is the antidote of choice, right? Now, once started, magnesium sulfate should be continued for how long? For example, let me just say, for example, if I ask you for how long should magnesium sulfate continue once started? All right. So let's say, for example, if a woman had a postpartum seizure, and then she was started on magnesium sulfate, then it should be continued 24 hours post delivery. Okay, so and if she has had an antepartum seizure before delivery, then it should be continued 24 hours post delivery or post last dose, post the first dose, whichever is later. Okay, so it should be continued. So magnesium sulfate should continue 24 hours post the first dose or 24 hours post delivery, whichever is later. Okay, so if she has had a postpartum seizure after delivery, if magnesium sulfate has been started, it should be given 24 hours from the last from the first dose. If it is an antepartum seizure, then magnesium sulfate has started before her delivery, but now it should be continued 24 hours post delivery, so whichever is later. Alright, so it should be continued for 24 hours. This is an important point to remember. Now, what other uses of Maxelf are there in obstetrics? The other uses of Maxelf, one is in the neuroprophylaxis. Neuroprophylaxis in case of extreme prematurity. Magnesium sulfate has been used for neuroprophylaxis in case of extreme prematurity. Magnesium sulfate has tocolytic action, but it is not used as a tocolysis. Tocolytic action is present, but it is usually not used because the tocolytic action happens at about 8 to 10 milliequivalent per liter concentration. So these are very high concentrations at which the tocolytic action is obtained. So what is seen is that it is usually not used because such high levels can lead to toxicity also, and anyways tocolysis does not need to be given for more than 48 hours. So anyways, magnesium sulfate, the main role is in prevention of seizures as far as eclampsia and preeclampsia is concerned. Secondly, it is used in neuroprophylaxis in case of extreme prematurity, and it has a tocolytic action, but it is usually not used as a tocolytic of choice. Alright, so these are the two important points. Second important point is that prolonged use with magnesium sulfate can lead to osteopenia in fetus. Okay, that is another concern with this. That is another concern with the magnesium sulfate use in preterm infants. Osteopenia can result in the fetus. Now, moving on to the next question. Question number 28. Oops, we left this question number 28 in between. Which of the following is not a cause of secondary postpartum hemorrhage? The answer to this question is placenta previa. It is clearly evident that placenta previa is placenta in the lower uterine segment, causes antepartum hemorrhage, it causes postpartum hemorrhage, and that to primary postpartum hemorrhage. It is not going to cause secondary postpartum hemorrhage. Secondary PPH is that hemorrhage which happens more than 24 hours after delivery to up to 12 weeks, right? To up to 12 weeks, and that happens, the most common cause for that secondary PPH is retained placenta. Retained placenta is the most common cause for secondary PPH, and other than that, endometritis, infection, polyps, all these are other causes of secondary postpartum hemorrhage. All right. All right. Now moving on to the next question. Question number 30. A patient having infertility is found to have bilateral cornual block. Best treatment that can be offered to her would be, the answer here, now the question here is asking you, there is bilateral cornual block. We know that bilateral cornual block, the most common cause for a bilateral cornual block is basically a false block. It could be because of the cornual spasm, right? But if we assume that yes, there is definitely a block, the best treatment that can be offered to her, because the question asks best treatment, the answer is IVF, in vitro fertilization. If they asked what was the next step, then the next step would have been laparoscopy and hysteroscopy. All right, because they are asking about the best treatment, okay, not that they are asking about the best treatment that can be offered to her. The best treatment that can be offered to her is in vitro fertilization, where we bypass the tubes altogether. So this is the answer for your this question number 30. So when we talk about All right. Now let us see question number 31. Question number 31 says, which one of the following drugs is not used for medical management of ectopic? Alright, now for medical management of ectopic, which is not used, here the answer is misoprostol. I think in your text explanations the answer given is incorrect. The correct answer here is misoprostol. Misoprostol is not used for medical management of ectopic. Misoprostol acts on the uterus, no. So there is absolutely no way that it is going to help in the management of ectopic. The rest are the drugs, KCL, methotrexate, actinomycin D, they can be given to kill the fetus, okay. So that is in an ectopic location as well. Now let us move on to question number 32. Question number 32. Contraindication syndrome results from the use of which drug during pregnancy? The answer to this question is warfarin. Warfarin is the drug that leads to contraindication syndrome. Contraindication syndrome deals with stippled epiphyses, and those are the things. In fact, the risk of warfarin embryopathy, is around 6%. And this is if the exposure is between 6 to 9 weeks. If the exposure is between 6 to 9 weeks, then the risk of warfarin embryopathy is around 6%. And this happens when the dose is more than 5 milligrams per day. Alright. Now this is the important point here. Now for the next, for the next topic of discussion and the next questions that I want to discuss with you, like we did this question here, medical management of ectopic. I want to talk about a number of questions in this exam set have been asked about ectopic pregnancy. So we will look at the flow chart of ectopic pregnancy, which I will discuss with you here, and then we will talk about the questions that are there. Okay, so let us see. Which questions are the questions which are dealing with ectopic pregnancy? So now the next question I will discuss is question number 31. I'll discuss question number 64, question number 87, question number 97, question number 103, question number 148, question number 153, and question number 188. Now these are the questions, these are the set of 7-8 questions which I want to discuss. All these are based upon ectopic pregnancies and their presentations. So let us just talk about ectopic pregnancy. Alright, now ectopic pregnancy is again now pregnancy outside the tube, that is pregnancy outside the uterus is ectopic pregnancy. The most common location of ectopic pregnancy is the tube, right? After the tube we have other less common locations, and where you have the rarest locations. Rarest locations are basically, your rarest locations are the cesarean scar site, right, and then we have the cervical ectopic, and then we have the abdominal ectopics. These are the less common ectopics. We can have ovarian ectopics also. Very, very important points about ectopic pregnancies which are asked, that in the tubal ectopic, alright, the most common site in the tube is the ampulla, and the most common to undergo abortion, the most common to undergo tubal abortion is the ampullary ectopic. The most common to undergo rupture, or the earliest to undergo rupture, is actually the isthmic, which undergoes rupture in about 6 weeks. the ampullary which ruptures at around 8 weeks, and ruptures late, that is your interstitial. Interstitial is the one which ruptures late. It can take as long as 12 weeks to rupture. So ruptures late, answer is interstitial pregnancy. All right. And even in interstitial pregnancy, you have to remember that if they ask you this question, which is diagnosed latest, if you have to choose between interstitial and abdominal, the answer is abdominal. Abdominal is diagnosed the latest and then followed by interstitial. All right. Now, next important point to remember about ectopic pregnancy is the risk factors. The risk factors for ectopic pregnancy, the most important risk factor is the previous ectopic. Okay, with one previous ectopic it is 15% risk, and with two prior ectopics the risk is about 30%. So the most important is previous ectopic. The second in this list, okay, the second is tubal surgery. Now, tubal surgery encompasses all the types of tubal surgeries, for prior ectopic, for infertility, sterilization procedures, so any kind of tubal surgeries as a whole group, right? Then the third important risk factor is PID and tuberculosis. So this is in this order, okay? And then the risk factors are smoking, right? And then other abdominal surgeries like previous cesarean, infertility treatment, and the sixth, the last, is the salpingitis ischemic nodosa to complete the list. Okay, salpingitis ischemic nodosa. What about contraceptions? Very importantly, questions are again asked now and again. What about contraceptive methods? All contraceptives, they decrease the absolute risk of ectopic. Okay, all contraceptives, they actually decrease the absolute risk of ectopic. It is the failure of contraception. It is the failure of contraception that is a risk factor for ectopic, right? And which methods, when fail, will give rise to ectopic pregnancy? Whenever there is sterilization failure. Which sterilization? Obviously, it has to be tubal sterilization or female sterilization. Then comes your IUCD, which is not IUCD, which then comes your Mirena, which is the progesterone containing. Then comes your IUCD, and then comes your progesterone only pill. Okay. Remember that the least is with OCPs. The least risk is with OCPs. Okay, the least risk is with OCPs. This is another important point to remember. All right. Next is the diagnosis. So let us see the flow chart here. So whenever there is an ectopic pregnancy, the diagnosis is pretty simple, right? Whenever there is an ectopic pregnancy, there is one presentation which will be classical ruptured. Okay, there is going to be history of pain or syncope. There is going to be, she is going to be having in shock. All right, so tachycardia and low BP, in shock, in signs of peritoneal irritation, guarding rigidity and everything, all these things. So this, on ultrasound there will be free fluid plus in the pelvis, right? And that will make the diagnosis of a ruptured ectopic. So a ruptured ectopic essentially becomes a clinical diagnosis, right? More or less, a ruptured ectopic becomes a clinical diagnosis. Even if you see not much amount of free fluid in the pelvis, the patient is in shock and signs of peritoneal irritation are there, then it could be a ruptured ectopic even with a lesser amount of free fluid in the pelvis. But free fluid in the pelvis is very, very important. In fact, you know, free fluid small amounts of free fluid can be seen even in unruptured tubal pregnancies. So that is why, ruptured ectopic becomes more of a clinical diagnosis, right? Similarly, whenever there is ectopic and it is unruptured. Now let us talk about the unruptured sort of ectopic, where there is amenorrhea, where there is a period of amenorrhea, where there is pain, where there is plus minus bleeding. Sometimes what can cause bleeding in ectopic pregnancy? The cause of bleeding in an ectopic pregnancy could be because of shedding of a decidual. There can be shedding of, sometimes shedding of decidual cast can be there. Okay, so that can also lead to bleeding. So anyways, there will be amenorrhea, pain, plus minus bleeding, that will be there. Then on clinical, then the first step in such a situation, is to rule out pregnancy, right? So we do a first step is to do a UPT. Then the question that they ask sometime, that if UPT is negative, does it mean that it is absolutely no ectopic? So UPT negative does not rule out ectopic completely. Okay, sometimes there can be an ectopic with very, very low levels of beta HCG, and then the UPT can come as negative. All right, so urine pregnancy test negative does not rule out ectopic completely. Okay, first important point. Then, so first step is a rule out pregnancy by UPT. At the same time, we go for a physical examination. At the same time, what are the physical examination findings which are important as far as ectopic pregnancy is concerned? The highest suspicion. The highest suspicion of an ectopic will come with the presence of an adnexal mass. If there is an adnexal mass, especially with a normal sized uterus, right, that will raise the suspicion of an ectopic pregnancy. Other suspicious findings, so this is the highest suspicion. This physical finding will give us the highest suspicion. Other findings are cervical motion tenderness, which are not very specific. They can be there with any uterine infection also, but mainly normal sized uterus, cervical motion tenderness, or if there is bogginess or fullness of the cervix. These are the other physical examination findings which raise the suspicion, but the highest suspicion is with presence of an adnexal mass. So whenever on UPT there is positive, the physical examination findings are suspicious of ectopic pregnancy, and the UPT is positive, and the clinical and physical findings suggest an ectopic pregnancy, we go for our investigation of choice, which is ultrasound. Which ultrasound? It is TVS. This is our investigation of choice, right? Now the first suspicion on an ultrasound will come with an empty uterine cavity. Okay, like I told you that between as early as 4.1 to 4.3 weeks, like we discussed in diagnosis of pregnancy in the first lecture, in the first part of the discussion here, we discussed that as early as 4.1 to 4.3 weeks, on an average at about 4.5 weeks, the gestational sac should be visible, right? So the first suspicion that will come is with an empty uterine cavity. So the first, as we go inside, we see the empty uterine cavity, and with a period of amenorrhea, we suspect ectopic pregnancy, right? Then there can be, sometimes there can be a pseudo G-sac also, which needs to be pseudo gestational sac, which needs to be differentiated. All right, but then there are other findings. There are other findings on ultrasound which are suggestive of ectopic. Those are, what are those findings? Those findings, the best finding would be to actually see a gestational sac at the location of a tube with cardiac activity, but that is random seen. The findings which are suggestive of tubal ectopic are the tubal ring of fire sign, Bagel sign, blob sign, and complex adnexal mass. These are the usual ultrasound reports which come with findings suggestive of ectopic pregnancies, usually unruptured ectopic pregnancies. Now let us assume a situation that there was an unruptured ectopic pregnancy. Unruptured ectopic on clinical and physical examination. Okay. Next step, UPT was done, which was positive. Next step, TVS was done, and TVS showed no gestational sac anywhere. What do we do next? If TVS shows no gestational sac anywhere, empty uterine cavity, or let's say an empty uterine cavity, the next step that we have to do is to do a serum beta HCG. Okay. Now there can be two possibilities. Either the serum beta HCG can be more than the critical value. Which is this critical value? This critical value is the discrimination zone, right? This discrimination zone is around 6,500 MIU per ml for transabdominal scan, and this is for 1500 MIU per ml for transvaginal sonography. All right, that means that these are the levels of this is the level of beta HCG that should be there at least, so that a gestational sac can be seen on transabdominal ultrasound, or it can be seen on transvaginal sonography. So that is what is meant by discrimination zone, and this is 6,500 ml for transabdominal and 1500 for transvaginal sonography. So there can be two situations: either it is more than the critical value, or it is less than the critical value. Right? Now, if the beta HCG value is less than the critical value, we will have to repeat the beta HCG value after 48 hours, and we will keep on repeating this after every 48 hours till your beta HCG crosses the critical value, and we are certain that we should be able to see the sac somewhere. Okay. So once on repeating the beta HCG values after 48 hours, if on repeating the values we see that the values are doubles in 48 hours, it means that it is a viable intrauterine pregnancy. Alright, most likely it is a viable intrauterine pregnancy. So we keep repeating the values every 48 hours. Once the value crosses 1500 MIU, then on TVS the viable intrauterine sac should be visible. That is the logic. But if the beta HCG value plateaus, then it is more likely to be an ectopic, and then we can consider monitoring the values, or we can consider doing a medical management depending upon that. If the value fails drastically, falls, if the repeat value falls significantly, alright, about 50% fall, if there is 50% fall, it means that it is an abortion or a failing intrauterine pregnancy. Alright, so it is an early pregnancy which has failed if they are significantly low values. Sometimes even with plateauing values, it might not be an ectopic, it might be a slow growing intrauterine pregnancy. Alright, therefore, we do not act upon one plateauing value, we keep repeating the values, but the questions for you which are asked in the exams are mainly concerned about this, that what will you do if the beta HCG comes less than the discriminatory zone. So we can see if it is doubling, it is viable intrauterine pregnancy. We can see if it is plateauing, it is more likely to be an ectopic. If it significantly falls, it is more likely an abortion or a failing intrauterine pregnancy. Right? Now, one part of the arm which we had left was what if it is more than the critical value. If it is more than the critical value, then what we can do, if the initial beta HCG is more than the critical value and we are not seeing a gestational sac anywhere, then there can be two possibilities. Either it is an ectopic pregnancy or it is a failing intrauterine pregnancy, it is an abortion. In any case, we can do what here we can do a DNC, and we can see if the products of conceptus, on DNC, what will happen if the products, they float in saline, that means that they are chorionic villi, and that means it is an abortion. The other point is that the products that are removed after curettage, they sink in saline, and then that is the other endometrial tissue, that means it is an ectopic pregnancy. Alright, so these are the other possibilities, that if the beta HCG is more than the critical value and we are still not seeing the gestational sac anywhere, we can do a DNC, see how the products are behaving in saline, obviously send them for histopath as well, but the report will come later. Nonetheless, immediate differentiation can be done by that and management started accordingly. Alright, now the next important point. So this is about how we are going to approach a pregnancy of unknown location, let's say. So all this management here was no GSAC anywhere, serum beta HCG less. So all this was a management of a pregnancy of unknown location, right? So once we have decided that yes, it is an ectopic, then you have to talk about the medical management of ectopic. When can it be done? What about the surgical management of ectopic, and what is the role of expectant management, if any? Okay, expectant management is do nothing, give no drugs, give no treatment, just monitor the beta HCG levels. That is what is expectant management. We're doing nothing, just monitoring the beta HCG levels. Talking about the medical management is suitable only for stable, motivated women, who are compliant and who are consenting and motivated to come for repeated follow-up. The HCG value is less than 5,000 international units per ml. The sac size is less than 4 centimeters, and preferably the cardiac activity should be absent. So these are the criteria for medical management. The contraindications for medical management, on the other hand, are not many. Obviously, unstable patient you will not attempt. Not consenting, not compliant, you will not attempt. Alright, then the next is any contraindication to methotrexate per se. Okay, so any contraindication to methotrexate, like liver failure or liver disease or renal disease or anemia, severe anemia. So all these things which are contraindicated for methotrexate use per se, they will be contraindications for medical management. And then the last that I would place here is HCG levels high. Now high HCG level shows that the sign of failure is more. With high HCG levels, the failure is going to be more. But is it an absolute contraindication? Not really. So that is why I will place it less. I will place it at a lesser number. I will place it at the 4th value. Then cardiac activity present, I will also put as this thing, and I will put it as a lesser number. That cardiac activity present is also going to be a contraindication. Right, coming on to the surgical management. The surgical management is very simple. Any unstable patient, hemodynamically unstable, you have to go for laparotomy. Alright, laparoscopy is usually not preferred in an unstable patient. If I say ruptured pregnancy, ruptured ectopic, but stable, so free fluid is there in the abdomen, but the patient is stable, then one can go for laparoscopy. So it is the hemodynamic stability which determines whether surgical treatment has to be done, whether laparotomy has to be done or laparoscopy has to be done. Does not depend upon the status being ruptured or unruptured. It depends upon whether the patient is hemodynamically stable or unstable. Alright, when we talk about, okay, the route is clear whether we go for laparotomy, laparoscopy. What do we do? Once inside, you have to remember that salpingectomy is the preferred treatment. You remove the whole tube, that is preferred, except for in situations where the tube is, except for the situations where you want to save the tube and the other tube looks unhealthy. If the other tube looks unhealthy, then we go for salpingostomy. Okay. So usually salpingectomy is preferred. If the other tube is unhealthy, we can go for salpingostomy. What about expectant management? What about expectant management? Expectant management will happen only if all present. What all present? Stable patient, the size is less than 3 centimeters, the cardiac activity is also absent, initial HCG is less than 1000 and it is in a falling trend. Such situations are not going to be met all the time, but if at all, expectant management can be tried. All right. Now, what next? Now, what are the drugs used for ectopic medical management? The drugs that are used are the most commonly used drug, the drug of choice is methotrexate. Okay, we give it as a single dose, we can give it as a double dose also, multi-dose schedule. Methotrexate is given, and then between day 4 to day 7, what we see a fall in 15% should be there. Okay, if not, we can repeat the dose. So that is more likely. These are the drugs. The other drugs, so methotrexate as the drug of choice. The other drugs that can be used is actinomycin D, that is also used. We can use mifepristone, we can use KCL, we can use vasopressin, we can use PGF2 alpha, hyperosmolar glucose. They have been used, but most commonly now with widespread availability, methotrexate is the drug of choice. To complete the list, these are the drugs which can be used, which have been used in the past. All right. Now let us move on to the questions that have been asked, and we will go discuss how these flowcharts will help us answer those respective questions. All right. Now let us come to question number 31. So 31, we have already discussed that the drugs out here, obviously it makes no sense that misoprostol would be used for medical management of ectopic. So that is the diagnosis. Next question, let us see question number 64. All right, look at this question. A 23-year-old, this is question number 64 we are discussing, a 23-year-old female patient presents with pain in lower abdomen followed by giddiness and fall. So there is pain and syncope. She is drowsy with a pulse rate of 110, BP of 94/68. So she has unstable parameters. Abdominal ultrasound was performed and it revealed the following findings. There is appearance in the right adnexa with moderate to gross hemoperitoneum. Uterus is normal. As you can see that this sign that it is showing, right? So this is the location of the tube where it should be. This is the tubal ring of fire sign. If they are asked you to identify this sign, this is a tubal ring of fire sign. There is a ring and vascularity on the outside. This is a tubal ring of fire sign. Okay, this is a tubal ring of fire sign. And you don't even need to look at the picture to be able to answer this question. It is ruptured ectopic. All right, it is ruptured ectopic, hemodynamic instability, classical findings. It is most likely ectopic gestation with possible rupture. Why is it not a hemorrhagic ovarian cyst? See, the tubal ring of fire sign can also be present with the hemorrhagic ovarian cyst, right? But the presentation which is reproductive age group female, all right, any time in a reproductive age group female comes in shock with a period of amenorrhea, the first thing that you suspect is an ectopic pregnancy, all right. Now moving on to the next question, question number 87. All right, look at this question number 87 here. All of the following are criteria for question number 87 I am discussing. All of the following are criteria for medical management of ectopic pregnancy except. So asymptomatic patient, yes, it can be managed medically. Serum HCG level less than 2000, okay, yes. Pregnancy diameter less than 5 centimeters. An unruptured tube. So the answer to this question is C. Pregnancy diameter should be at least less than 4 centimeter, then only it can be a criteria for medical management. Okay, so that is why, as you can see, serum HCG, beta HCG level less than 2000 is obviously definitely a criteria. See, some international guidelines give 2000 as the value, some international guidelines give 5000 as the value. It doesn't really matter, the lesser the better. There is no clear cut off that beyond this level you cannot give medical management. But obviously pregnancy diameter should be less than 4 centimeters, that is a clear cut criteria, and cardiac activity should preferably be absent. That is also very important criteria. All right, next moving on to question number 97. Most common symptom of ectopic pregnancy. Now this is a very simple question. The most common symptom of ectopic is pain. All right, bleeding, pain is, why is pain happening in ectopic pregnancy? The pain in ectopic pregnancy is because of the stretching of the tubal capsule. All right, stretching of the tubal capsule. Right, once the pregnancy ruptures, the tubal rupture that happens, why does it happen? It is basically a vascular insufficiency, right? It is a vascular insufficiency that happens because the pregnancy, see the tube epithelium, it lacks a submucosa, so the pregnancy keeps burrowing inside, all right, and then there is vascular insufficiency, and that leads to bleeding outside the tubal, outside the mass of outside the gestational sac. Okay, the gestational sac which is there burrowing deep into the tubal musculature, because it lacks the submucosa, there is vascular insufficiency, and then that leads to ultimately tubal rupture. And with that rupture, what happens? Rupture no longer causes pain. All right, once rupture happens, the woman goes into shock, and then she becomes symptomatic with signs of peritoneal irritation like guarding, rigidity and tenderness because of the presence of hemoperitoneum. But pain in the unruptured state is basically because of stretching of the tubal capsule. How about bleeding in ectopic? Bleeding in ectopic, I told you, it can be because of shedding of the decidua, uterine decidua, that can be shed in the form of a decidual cast also sometimes. Sometimes it can be in the form of a decidual cast, sometimes may not, then it can be just bleeding. Abortion is not a symptom, infection is not a symptom as such. So this is about question number 97. Question number 103. Let's come to question number 103. Regarding medical management of ectopic pregnancy, all are true except, okay, let us see each option one by one. Initial beta HCG is an indicator for the number of total doses required. This is a false statement, okay. This is usually not the case, okay. So it doesn't matter, there is no clear cutoff that, you know, beyond this level, beyond this beta HCG level, you should give 2 doses, or if it is less than this level, you should give a single dose, or you should go for a multiple doses schedule protocol. So it is just a clinical assessment. Usually people prefer that if it is a higher beta HCG, one gives multiple dosages or double dosages, but if it is lesser, they give single dose. Whether there is one value over which this should be done, it is not specified. So therefore this blanket statement that initial beta HCG is an indicator for number of doses required is a false statement. So the correct answer is this is a false statement. If you see the other statements, these next of the 3 statements are true statements. Failure rates increases if cardiac activity is present. This is true. So cardiac activity, that is why, should preferably be absent. HCG, best prognostic indicator for success is initial HCG. That is also true. Alright, the lower the beta HCG levels, the better the chances of success among all the factors, be it the beta HCG, the cardiac activity, the sac size and everything else. It is the best prognostic indicator is the initial levels of beta HCG. And a baseline CBC, LFT, KFT is performed. That is also true because in medical management we are going to give methotrexate. For methotrexate we need to have these baseline levels because methotrexate has effects on the liver function tests, on the kidney function tests, and also can lead to neutropenia and anemia and pancytopenia as well. Alright, now come on to the next question. Let us see question number 148. Alright. Let us see question number 148. We are doing this question. A woman attends antenatal clinic with complaint of mild pain in lower abdomen on left side. The periods are regular and UPT has been positive at home. So what do? We do a TVS and the uterine cavity is empty and there is no adnexal mass. So diagnosis of pregnancy of unknown location, right? So mild pain, periods have been regular, UPT has been positive at home, so at least she is more than a month overdue, right? So uterine cavity empty, no adnexal mass. The next step is perform a beta HCG. This beta HCG is less than the critical value, so the next step is perform beta HCG after 48 hours. Alright, if the beta HCG would have been, let us say in this very question, if the beta HCG would have been 3000 and on TVS the cavity would have been empty, then the answer should have been DNC, right? But if DNC is not in the option, then one could go for a direct single dose of methotrexate also. Then in that situation, first choice is DNC, the second choice is, some people say that if the TVS is empty, there is no sac seen anywhere, let us assume that it is an ectopic and give her direct methotrexate. This is the second choice, but ideally DNC should be the first choice. Question number 153. Excuse me. Question number 153. A third gravida is admitted with complaint of sudden onset right-sided lower abdominal pain after a period of 5 weeks of amenorrhea. Pulse is 130, BP is 80/50. There is large amount of free fluid in the pelvis and empty uterine cavity. The next step is unstable patient, amenorrhea, large amount of free fluid. She is managed as ruptured ectopic, and in this situation, because she is unstable, we will choose urgent laparotomy. We will choose urgent laparotomy. There is no laparoscopy, methotrexate, nothing doing. We choose unruptured. We choose urgent laparotomy. Now next, let us see question number 188. A 20-year-old female with 1.5 months of amenorrhea comes to the casualty with complaint of pain abdomen. So she is 1.5 months overdue. 1.5 months is approximately like 6 weeks. Okay, she is carrying with her an ultrasound report which shows only thickened endometrium. So nothing very significant on ultrasound. So there is nothing in the uterine cavity. There is no other abnormality. What is the next step? In this situation, the next step should be to perform a urine pregnancy test. Why do you want to perform a urine pregnancy test? She is a young girl, 20-year-old female who has come with 1.5 months of amenorrhea. She might as well be pregnant. And in such a situation, when there is only thickened endometrium on the ultrasound, in such early period, usually ultrasound will probably not show anything. So the first step is to determine whether she is pregnant or no. So we do a urine pregnancy test. A serum beta HCG test will take, obviously you'll have to take a blood sample. The report will come in a couple of hours, whereas performing a urine pregnancy test is a cheaper, simpler alternative to confirm the presence of a pregnancy. If the UPT is positive, then it becomes a cause of concern that, okay, yes, this thickened endometrium, and she could be ectopic with a negative if a UPT is positive, So the first step here is to determine whether she is pregnant or no. So first pregnancy rule out we can do by UPT. If the UPT is positive, then we'll go for the beta HCG, because ultrasound actually did not show anything anywhere. This we can go for later. We can go for beta HCG directly also. But then ideally, if the option is between urine pregnancy test, this is the better answer, because it is simple. Urine test, urine sample is required. You will get the result there and then in front of you. It is much cheaper. It is a 50 rupee test, whereas for the serum beta HCG, report will be available after a couple of hours. It will require a blood sample. Okay. So this is about the ectopic pregnancy. Okay, now let us move on to the next set of questions. What are the next set of questions where we left earlier, Where were we? I think we should begin with question number 33. Yes. We should begin with question number 33, and question number 33 Alright, question number 33 is asking, identify the presentation shown below. So what is this presentation shown below? This presentation shown below is frank breech. Very, very easy question. It is frank breech. So let us just note the important points about breech presentation. So if we were to see, alright, so like it was shown in this figure here, this is what is frank breech, right? This is the breech. Breech is the most common malpresentation, is breech. Most common malposition is right occipito-posterior. So occipito-posterior position is not a malpresentation, it is a malposition. So the most common malpresentation is breech. First figure here, this is frank breech. This here is the complete breech or flexed breech. This here is the incomplete breech. Alright, and as you can see here, this particular type is the footling breech. We can have footling presentation, we can have knee presentation also. This is a footling breech. Here, this is an incomplete breech. Alright, and this here we can see is the transverse lie. Sometimes they have asked this question also, transverse lie. Transverse lie means the lie is transferred, but it is a shoulder presentation. The presentation is shoulder. right? In this, the denominator is the acromion on the shoulder. Right? Now, very important point about what is so important about frank breech, complete breech and incomplete breech and the transverse lie. If we talk about cord prolapse, cord prolapse is a very deadly complication, and the maximum risk of cord prolapse is seen in transverse lie. After transverse lie, it is seen in, among all the three breaches, it is seen in footling breech, then it is seen in complete breech, and then least is seen with frank breech. Okay, of course the least is going to be with cephalic presentation, but we are not including that in our list. We are saying the least among all the breaches, the least risk is in frank breech. Alright. Alright, now what other questions do they ask? What other questions do they ask about breech? Let us just talk about that. The most common cause of breech is basically prematurity. Alright, it is prematurity. At around 28 weeks of gestation, 25% of the fetuses are breech, right? And at term, around only 3% remain as breech. So there is spontaneous version that is happening. In fact, if they ask you what is the most common most common cause of fetal morbidity in breech, right? The answer to this question is also because of prematurity. The most of the times the morbidity that the fetus suffers in breech presentation is basically because of associated prematurity. Alright, but if they ask you what is the most common cause of fetal death in case of breech pregnancy, sudden fetal death, then that is intracranial hemorrhage. Then the answer to that question is intracranial hemorrhage. Alright. If they ask you what is the most common cause of transverse lie, then the answer to this question is again prematurity. Okay. But if they specifically ask you most common cause of transverse lie at term, then the answer to this question is placenta previa. Placenta in the lower segment will cause the fetus to assume a transverse or an oblique lie. So most common cause of transverse lie at term is placenta previa. Alright, now management, let me just talk about the clinical management of breech pregnancy. Clinical management, and just let us do the clinical scenarios and then we'll see to it. So whenever there is a woman, she comes to the antenatal OPD and she is, let's say, 35 weeks and she is breech. Alright, and let's say she is primi, or irrespective, let me say she is multi also, it doesn't matter. Prior vaginal deliveries. Prior vaginal deliveries. Okay. Antenatal OPD, she comes at 35 weeks, she is breech, she is either primi or multi, she has prior vaginal deliveries. What do we do next? The next thing that we do here, and there is no other antenatal risk factor, like there is no preeclampsia, there is no heart disease, there is no placenta previa, no abruption, no complaint of bleeding, anything. So on the other hand, the antenatal otherwise looks uneventful. Then the next step here is to do an ultrasound, to schedule an ultrasound. Why do I want to schedule an ultrasound at 35 weeks? I want to schedule an ultrasound at 35 weeks. A, to rule out any gross congenital anomalies, to see if the baby is okay and healthy, to see if the liquor is adequate. Okay, to see if the liquor is adequate, to see if it is, what about the head? the head is extended or not. Sometimes in frank breech the head can be extended. Okay. So these are the three things that I want to rule out here. Ultrasound, I want to see the rule out gestation. I want to see the liquor. I want to see and I want to establish that the placenta is not low lying. I want to establish that the placenta is not low lying. So I have scheduled an ultrasound. I have seen all these things, right? If everything looks okay and there is no other contraindication for vaginal delivery, if such is the case, no other contraindication for vaginal delivery means that the placenta is not low lying, the pelvis is adequate, everything is okay, the baby is average size, then I plan for external cephalic version at 37 weeks. This is what I am coming to. Okay, external cephalic version at 37 weeks. All right. There are only two indications. There are only two indications of an absolute indication for cesarean section in breech. Only two indications of two indications for doing a cesarean section in breech. One is the stargazer breech. Stargazer breech is also called as breech with extended head. Okay, and the second indication is footling breech. These are the only two indications for doing absolute indications for doing cesarean section. There are certain relative indications for cesarean section in breech. Now these relative indication means that if they ask you a question clinically, in the sense that if they give you a scenario where the woman is term 37 weeks with this condition, what should you do? Should you do an external cephalic version? Should you do a cesarean section? Then you answer cesarean section. Alright, but if they ask you this question, similar question can be asked differently. How differently? It can be asked like all the following are all the following are indications for cesarean section in breech except. Then the except one will become the relative indication. Then you will answer accordingly. Alright, so you will choose the absolute indications for cesarean section first and you will keep the relative ones at last. So indications, relative indication of cesarean section, where cesarean section is preferred, is primary breech, alright. However, if you have answered like the first question, you do external cephalic version. Okay, so you do external cephalic version in primary breeches. So in primary breeches, if they ask you independently, if it is primary breech, then you do external cephalic version. If she is not willing for external cephalic version, so offer external cephalic version. If she is not willing for external cephalic version, then you can do cesarean section. So in primary breech, external cephalic version should be our first choice. Then we have previous cesarean section with breech, precious pregnancy with breech, and you have preterm breech, breech with IUGR, macrosomia with breech. These are the relative indications for cesarean section with breech. Next situation is what are the prerequisites for external cephalic version. So like I discussed, what are the prerequisites? The prerequisite, she is 37 weeks, and another important point is that it can be even done in early labor. So it can be done in early labor, and then then tocolysis can be used. Tocolysis with 250 micrograms of terbutaline single dose can be used. Okay, it is not mandatory, but it will improve. Tocolysis is not mandatory, but if the uterus is getting contractions, then it can improve the success rate. So this is the thing, we can use this thing, right? And prerequisite, should the OT should be free, the staff should be free, with all preparations set for an emergency cesarean section. Then ideally it should be a healthy mother, the baby should be healthy. What do I mean by baby healthy? By baby healthy, I mean the liquor is normal, I mean that there is no gross congenital anomaly, and I also mean that by healthy mother, that means that there is no other risk factors. Okay, so and the pelvis is adequate, and obviously the woman has given consent. So these are very important points, and there is no contraindication for vaginal, right? By default, let us just note the contraindications for performing external cephalic version. Alright, to know the contraindications of performing external cephalic version, it is very simple to remember. Obviously, absent membranes. Absent membranes, that liquor has all leaked out. Liquor is going to leak out. So absent membrane is a contraindication. Oligohydramnios is a contraindication. Gross congenital anomaly in baby. Now, when we talk about gross congenital anomaly, I want to also mention that it will depend upon what kind of an anomaly it is. Like for example, if it is a hydrocephalus baby, then a baby who has big head will not be also be able to deliver vaginally, right? Then what happens in those circumstances? We see if the baby is salvageable. If the hydrocephalus is mild and we have decided that the baby does not have any neurological impairment, and we want to give the baby a chance of life, then we will choose a cesarean section. But if we want to sacrifice this baby, then we will choose a vaginal delivery. So both options are there, alright, depending upon the severity of the hydrocephalus. So all in all, if it is a gross congenitally deformed baby, then we do not prefer to give external cephalic version. In fact, external cephalic version becomes contraindicated. Then they are allowed to deliver vaginally. Contraindication for external cephalic version does not mean that that cesarean section is done for them. Does not mean the same thing. All right. So absent membranes, GCA in baby, these are contraindications. Okay. Placenta previa is a contraindication for external cephalic version. Antepartum hemorrhage, twins, obviously these are contraindications. Okay. Preeclampsia is a contraindication for external cephalic version. Another important point is that there are certain relative contraindications, okay, which is previous cesarean section, okay, and macrosomia. These are relative contraindications to external cephalic version. Okay, where external cephalic version is relatively contraindicated, that means it is usually not done. Such babies are usually done, for such babies we usually do cesarean section. Okay, so this is about, in a nutshell, about the prerequisites for external cephalic version. So we have to remember about the contraindications, the relative contraindications, and these are the important points. Tocolysis is not mandatory, but it can be used to improve the success rate. One has to establish this, that the baby mother is healthy, there is no risk factor, the baby is healthy, the pelvis is adequate, consent is there is no contraindication for vaginal. You elaborate all these points and you come to getting the contraindications for external cephalic version. Remember these points, and then there are certain relative contraindications where usually it is not done, which is previous cesarean section and macrosomia. These are relative contraindications. Another important contraindication is, I told you, baby healthy. Another complication is IUGR with deranged Doppler. If there is already IUGR with deranged Doppler, usually we do not do external cephalic version, alright. So IUGR with deranged Doppler is another contraindication for vaginal delivery of external cephalic version. Then such a fetus should be delivered by cesarean section ideally. Alright, placenta previa with breech, cesarean section. Antepartum hemorrhage with breech, cesarean section. Alright, twins with first baby breech, cesarean section. Preeclampsia with breech, cesarean section. Alright, absent membranes, oligohydramnios with breech, preferably cesarean section. Similarly, previous cesarean with breech, preferably cesarean section is usually preferred by most of the people. So this is how the permutation and combinations of questions can be there in case of external cephalic version breech presentations, or simply one-liners can be asked, all are contraindications except. If all are contraindications are asked, then if you in the option there is previous cesarean section, then you don't go for external cephalic version. Then you say that this is not a contraindication because it is a relative contraindication, right? Similarly, post-maturity. Post-maturity is again a contraindication. Why is it a contraindication? Post-maturity for external cephalic version becomes a contraindication because the liquor is significantly less in those situations. So post-maturity is again a contraindication for external cephalic version. Cesarean section should be preferred there. Alright.